Okay, yeah. Thank you, Professor Janousek. I think now you're going to take us through a procedure that you used the OneStim on and discuss how you used it and what the outcomes were.
This is a case we've got recently. This was is a 6 weeks old male infant, and the patient came in from a regional hospital with severe hemodynamic compromise, having a wide QRS complex tachycardia. So this is the ECG we got during presentation. So these are the lymph leads. So you barely see nice QRS complexes, but you may guess there are some, and they are it's a very high rate. And the cycle length is here 190 milliseconds. We could see better ECG in the precordial lead. So these are the precordial leads. So it's a wide QRS tachycardia. The patient would have narrower QRS complexes if he would have sinus rhythm. It's a small baby, and the cycle length is 190 milliseconds. So with this situation, with colleagues on duty, it was later in the afternoon. So we just did cardioversion because we didn't know what kind of rhythm is it, whether it's his ventricular tachycardia or supraventricular tachycardia. By having this child compromised, we just cardioverted, intubated and cardioverted. Otherwise, if the condition would be more stable, we would probably go in with the transoesophageal lead and record the atrial potentials and see whether the atria, the rate is higher or equal or less than the ventricular rate, and then have some idea of the differential diagnosis. So once we cardioverted, we got this ECG, and at the first glance, you can see there is ventricular pre-excitation. Mm-hmm. So now we have the diagnosis actually that it's a patient with the Wolff-Parkinson-White syndrome, 6 weeks old, with a very fast wide QRS tachycardia, but 99% probability that it's caused by, it's a pathway-mediated tachycardia due to the Wolff-Parkinson-White syndrome and accessory pathway. The special thing in this patient is we have wide QRS complex tachycardia as an initial presentation. So this is not very often, even if the babies have high rates, they have mostly narrow complex tachycardias while having accessory pathways and WPW. So having this setup of wide QRS complex is quite rare. So we thought what could be the reason. So there are some reasons for that. I think I have stated them later. But if we have looked at the pattern, the QRS pattern here, actually the QRS pattern is different from the pattern during tachycardia. So it doesn't really look like that would just be a more pronounced or complete pre-excitation during tachycardia, and it would just be an antidromic tachycardia. So we thought it may even be there is two pathways, and the two pathways might be an explanation why we get such a fast tachycardia, because it's actually going through one pathway from the atrium to the ventricle from the other back. So I will not give you the complete clue whether there are two pathways. We are not able to sort it out even with our transoesophageal pacing study that we did, but what we did I'll show you. So this is the transoesophageal EP study we did in the beginning before starting any drugs. And this is the esophageal atrial signal here, nice sharp signal. This is the far field ventricular signal. These are two surface leads, lead 1 and lead 3. So you can see nicely the delta wave here. You can see the atrial potential. So we have a nice site to pace from the esophagus. Then we did the A-stim study, and as you can see here, with this extra stimulus, we produced a premature wide QRS complex beat. Whether again this is just more pronounced or complete pre-excitation, or is another pathway, or is just aberrant due to bundle branch block, I don't know. I suspect there is two pathways, seeing the clinical condition. And then we get a wide complex tachycardia, which again changes the QRS morphology and a little bit the cycle length. So again, this may give you some suspicion there is two pathways, but it may be just one pathway and aberrant conduction as well. So we did induce the clinical tachycardia, or the rate was, as with the clinical tachycardia, you can see here the one-to-one relationship of the atria to the ventricles. So there is proof that it's a kind of AV re-entry. And we stopped it again with pacing. Here again, the tachycardia recording a little bit more clearer ECG. So the questions, as I said, is that antidromic AVRT, aberrant orthodromic AVRT, multiple pathways related AVRT, we don't know. If this would be multiple pathways, it's really a high-risk situation for the baby, because if you have multiple pathways, the risk that you had atrial fibrillation very quickly conducted to the ventricles and you induce ventricular fibrillation and then have sudden death as a consequence is really a risk here.
Yes.
So that was the reason why we did the study in the beginning, to see what is at the baseline and what we can achieve with the antiarrhythmic drugs. And there is a second study on Sotalol. We mostly start with Sotalol in the babies, and we have good experience with Sotalol for supraventricular tachycardias, which are pathway mediated. And we did increase the dose up to 140 milligrams square meter BSA. We mostly go up to see a decent prolongation of the QT. Yep. It's not really the QTC, because the QTC is depending also on your pre-excitation. Once you have a delta wave, your QT will be longer, your QTC will be, of course, longer. So we observe an absolute increment in QT, QTC, rather than just the values that would be compared to a normal limit. So we may have, with such a pre-excitation, a QTC even without the drug over 40 milliseconds, and then we see the electrophysiologic drug effect just by observing a certain prolongation of this QTC, not getting to a very hugely prolonged QT intervals. But mostly, even with higher doses of Sotalol, we almost never had any proarrhythmia with that kind of drug in babies with a normal heart. So we are not so much afraid of Sotalol here. And here is a follow-up study on 140 milligrams per square meter body surface area, and our range is 80 to 180, let's say. In newborns, we try to use less, but mostly less is not effective. We have to increase anyway. Here, when we do the same stim protocol, we don't get a wide QRS complex anymore here, and we prolong the refractory period of the pathway, and we get conduction through the AV node here. So that was one of the proofs, and I don't get through all the pacing protocols we used, but that one of the proofs that we have done something good to prolong the refractory period of the pathway, which is part of the job or pathways, if there would be multiple, which is part of the job to decrease the risk of rapid atrioventricular conduction. It doesn't say you anything really about the inducibility, because even with increasing refractory period, you may still be inducible. It depends on the complex relationships in the re-entrant circuit.
Yeah.
And the last one, I think we tested, and that is what we are doing for pathways in the EP lab as well. We are testing for the shortest pre-excited RR interval by doing incremental pacing from the atrium. And here you can see we have one-to-one conduction through pathway pre-excited QRSs, and here we lose one-to-one conduction. So we have here the shortest pre-excited RR, which is another parameter how to assess the effect of antiarrhythmic medication on the pathway. Yes. So finally, during that study on Sotalol, we didn't get we prolonged the refractory period and had no induction. So that was like our outcome, and we dismissed the patient home. And actually the patient was okay, had just short runs of tachycardia documented by a home monitor, yeah. But well correlated. Yeah. So the conclusion is, as many of that has been discussed before, that we can do just repeated studies. It's easy to carry it out with the OneStim, and we get good signal quality. And we use the standard diagnostic steerable decapolar EP catheters mostly, even for transoesophageal pacing, and we may store and export the ECG curves. And as shown in the case, it allowed us for confirmation of prophylactic anti-arrhythmic drug effect, in this case in a life-threatening AV re-entrant tachycardia and WPW in a small baby. So that's it.
Great, thank you. That's a really good presentation, and yeah, using the system to help understanding the delivery of the medication to affect that refractory period, so that the patient's arrhythmia couldn't continue. That's really good.
Of course, you know, we cannot model completely the relationships in the re-entrant circuit, because it's an interplay of different refractory periods and different conduction velocities in different structures. So it could be probably modeled by some computer modeling if we could measure the respective velocities.
Yes.
But we cannot measure it mostly in the whole circuit, or it would necessitate a quite complex EP study.
Yeah.
So anyway, even by proving that we decrease the conduction capacity of the pathway, it doesn't really mean consequently that we decrease the risk of AVRT. We may change the properties and get more easily AVRT induction or spontaneous AVRT. This may also happen. So it's a kind of proarrhythmic effect in terms of the AVRT. So anyway, it's there needs to be a period where we look at the patient and see whether there is spontaneous episodes or not. Yeah, but we can at least test the risk for very rapid conduction over the pathway from the atria to the ventricles in case there is atrial fibrillation. Because if we increase refractory period, the likelihood of very rapid contraction is decreased.
Yes. Yeah. Okay. And where was this procedure carried out?
In the ICU.
In the ICU.
Yeah.
Okay. And just talking, you mentioned earlier about the system and its usability with maybe some of the ICU staff. Do you find that, so you are required, or your EP colleagues are required to support them in the use of OneStim?
So far, yes. I think it needs some learning period for the other staff. I think the basic problem is that you don't do it daily.
Yes.
Yeah. And once you do it once in 5 years, you all the time forget everything. Yeah. So that even if you train the people and then don't do it regularly, that's a little bit prohibitive. Then do it effectively in the setting of such a life-threatening environment. So then it's probably easier just for overdrive to take the simple pacemaker. But in this case, I have just advised to Cardiovert, because it's the simplest, most effective way how to terminate everything or almost everything you may get. Yeah.
Yep. And an emergent situation, obviously, that you don't want to cascade. Okay. Look, thank you very much for your time today.
Thank you, Greg.
It's been great. We're glad that we've been able to provide you with a device that's helped you treat your patients. And thank you for taking us through this procedure.
Thank you as well. And it's extending our options, which is a good thing. And I think it's still evolving field, going into that stuff of intraoperative ablations again after 40 years, let's say historically, because that is how it has started in the operating room, and now we are getting back in specific situations and indications. For different substrate, of course, not more for the, mostly not for pathways, sometimes also for pathways.
Yeah. Unfortunately, we've got a helicopter landing, but I think there's a saying that goes, everything's old is new again. So, you know, maybe, certain practices from that were used frequently before transoesophageal, we might find them now with OneStim being used a bit more often again. So that's great. All right. Well, thank you very much.
Thank you, Greg.
Thanks.